This session sounds quite really interesting, and I would like to see what sort of unusual PCI we're looking at. So can I invite Dr. Christina Mew? Are you here? Hi. To share with us updates for treatment of post-MI heart failure.
Actually, there's
Christian.
a mistake in the title. Initially, the title was going to be really, I guess, well, I'm a fellow from Australia, and I'm very fortunate to be learning from the team at Tuen Hospital in Hong Kong this year. So I was hoping to share with you sort of what I've learnt in my last 8 months there. And I've chosen a case that sort of encompasses a lot of the major learning points that we've made this year for CHIP cases. And thank you very much for inviting me to and share my experience at SIF 2025. I have no disclosures. So the case that I'd like to share is a 71-year-old gentleman who presented with a high-risk non-STEMI. He has a background of type 2 diabetes, hypertension and smoking. He was pretty active 71-year-old. He was still playing badminton regularly up until a month ago when he started noticing claudication. Shortly after his presentation, he had recurrent chest pain on the ward, and that's his corresponding ECG. And you can see it's a pretty ugly looking, and it's a new right bundle branch block. His troponin peaked at 13,000, and his transthoracic echo showed severe left ventricular dysfunction with an ejection fraction of 25% and moderate functional mitral regurgitation. So this was his diagnostic coronary angiogram. I'll let this run for a bit. But really, I'm sure you can all appreciate that he has severe triple vessel disease and he has severe coronary calcification. Just to point out some of the highlights, his right coronary artery had tram tract calcification, culminating in a CTO distally. His circumflex had this critical osteal lesion, as well as this massive osteal calcific rock there. And his left anterior descending artery had this thick calcific shelf with a true calcific bifurcation lesion. And it also was the donor vessel supplying collateral flow to the RCA CTO. So in the first instance, we referred for coronary artery bypass grafting. So this is his workup towards surgery. You can see his LV dysfunction. And we did a CT chest given his risk factors. And unfortunately, this did show porcelain aorta. But importantly for us, it actually also showed severe aortoiliac disease. And I'll have some stills in the next slide. If you focus on the aorta here, there's no contrast or pacification past the distal aorta. So distal to the IMA was occluded, and bilateral iliacs were also occluded. So, unsurprisingly, he was turned down for coronary artery bypass grafting due to high surgical risk. And while he was on the ward receiving optimal medical therapy, he had recurrent chest pain with re-elevation of his troponin, indicating a recurrent non-STEMI. So he had failed medical therapy. The patient and the family very much wished to have intervention, understanding of the significant risks. And so we worked very closely with our vascular colleagues to try and come up with a solution to treat his vascular problems. And this is the first major learning point as a fellow, was how to assess for a complex PCI, how to assess the patient adequately and be adequately prepared. So broken them down into patient factors, anatomical factors, and procedural factors, and we looked at each item carefully. But really, I guess the summary of all of that is that he has a bad pump, he has bad coronaries, and he has bad vascular access. So this would be a true CHIP PCI case. And given the very limited vascular access and the severe left ventricular function with two very fresh acute coronary syndromes, we wanted to have upfront mechanical support. But the big barrier was, well, how do we get an impeller in? So speaking with our vascular surgeons, they were very happy to provide subclavian support or access, but that wouldn't treat his peripheral vascular disease. Given that he was symptomatic with his claudication, they offered, hey, how about we try and revascularize his aorta and iliacs? That would treat his peripheral vascular disease and hopefully allow you guys to do impeller PCI to fix his coronaries. And after a lot of discussions with the family, that's what we embarked on. So on the left panel here, you can see that this is a retrograde injection up into the aorta and confirming that it is occluded distally. They were unsuccessful revascularizing from a retrograde fashion, but they were successful antegrade working from the left brachial artery. And they used what we thought was a very interesting technique called a paving crack technique, where they had upfront kissing covered stents. So they put in upfront covered stents and essentially in the distal aorta and the bilateral iliacs, and essentially went in with very aggressive high pressure post dilatation. And because of the covered stent, they needed to do a chimney stent of the IMA. You can see in the middle panel there, despite very aggressive high pressure dilatation, that there's still significant stent under expansion in the distal aorta bifurcation, just indicating the severity of his disease. But you can see that the flow is restored, and hopefully this would be enough room for us to get our impeller through. So now is our turn. So we planned for an upfront 14 French impeller, and then because of the limited vascular access, during his diagnostic coronary angiogram, we discovered that his subclavian and brachiocephalic artery were very tortuous. We could barely manipulate the diagnostic catheters in, and we envisioned that this would be difficult for PCI. So we opted for a single access with the PCI sheath piggybacking off the impeller sheath. And then we would use our arsenal of calcium modification techniques with rotablation, orbital atherectomy, and more conventional scoring in NC balloons. And then we would do a hybrid approach with left main bifurcation stenting and hybrid drug-eluting stents and drug-coated balloons. And this would be under OCT guidance. So this was the first thing. So we did a left femoral artery puncture, and I think we all held our breath here as we advanced the impeller, seeing it all get through. And after a few gentle to moderate pushes, it eventually passes. So that was very fortunate. And so we continued with our planned approach. So we performed a rotational atherectomy. We chose a small burr size, 125. That was mainly because we wanted to burr the LAD, the diagonal, and the circumflex, and we wanted to minimize time and use the same burr for all three vessels. So initially the 125 didn't pass, and then on the second run it did get through the lesion. But then this is what happened on the hemodynamics. There's a blood pressure crash. So first thought I had was, oh, I've already perforated. But let that play. But thankfully there was no perforation. And then this is the next learning point for us fellows is trying to work through the different differential diagnoses of hypotension in the cath lab. So next we turned our focus to the access site. There was no hematoma around the access, but this was a left femoral puncture, and what I discovered is on that far side of the table there was blood pooling in the folds of the drape on that side. And what happened was with the single access during the PCI sheath had come back about 1 centimeter from the hub of the impeller sheath, and because of that angle of that puncture, it had just split open the impeller sheath. And because paying attention to other things, that this actually allowed a lot of blood loss. And so there was a sick patient, and then we had glycerol trinitrate in our rotor fluid, and I guess during the rotor run, this just all unmasked that he was actually now very hypovolemic. So we had fluid resuscitation, dopamine with the impeller, with blood transfusion, but just pushing back that 7 French sheath back to the hub of the impeller actually sealed it off again, and there was no more bleeding. So from that perspective, things were secured, but the patient was agitated with the hypotension, so he ended up being intubated and ventilated. After things settled, we continued with our plan. So we finished rotoring the LAD, then we rotated the first diagonal, and then the left circumflex artery, all with the same burr. And then next, because of that ostial circumflex rock, we opted for retrograde orbital atherectomy to really try and get the wire bias to treat that ostial lesion. And then this is the angiogram post-rota and orbital, demonstrating that it's a bit of dissection, which I guess is our goal to modify these lesions. This is the OCT of the left circumflex artery going proximal to distal after the rota and orbital. I've got some stills on the next slide. What we can see here is that we've made some fractures in the ostial circumflex. There's what thankfully probably is more an eruptive nodule, so we were able to modify it. And then in the mid circumflex here, that there wasn't any dissection, and so that's where we planned for a drug-coated balloon. So going back to the LAD, we finished that with scoring an NC balloon to the first diagonal, and then we treated that with a drug-eluting balloon. And then we stented across the diagonal into LAD. So the mid LAD had a 33 stent. And then we planned for that left main bifurcation stenting, which we used a nano crush technique for. So we also scored the circumflex ostium, and then we implanted a stent with minimal protrusion into the left main. And then we post-dilated that and then stented the left main LAD. We performed POT, then rewired and performed kissing balloon, then final POT. So this was the OCT run of the left main LAD. Still a little bit of stent under expansion. So after this run, we did further post-dilatation. A little bit of malposition. So I was taken care of by further post-dilatation. And then this was the final result. So he was discharged home on the 3-month review. He had quit smoking, he was back walking, and he was asymptomatic. And we've opted to medically treat his RCA CTO in the first instance. So in conclusion, it was a successful case where we collaborated very closely with our vascular team and also highlighted the importance of teamwork in the cath lab for a very high-risk case. I mean, the case itself was difficult, and then having complications, having a good team around was very important. And there were quite a lot of learning points, as I alluded to, for us fellows. Thank you very much for your attention.
Thank you, Christina, for that truly cheap case. Well, Impella is not readily available in this part of the world. And so I was thinking actually an easier approach is to put IBP through the left brachial. And that will give you the mechanical support needed, and without that bleeding complications if I have no options of vascular access and the impeller is not available and so forth. What do you think?
Yeah, I think I just do wonder if, having come from a centre that didn't have impeller previously and then now working in a centre with impeller, can sort of see the cases, the difference. Sometimes balloon pump is adequate, but having that extra impeller support makes a world of difference, even if it's just buying you time to finish your PCI. So I think if we didn't have impeller, we'd probably be reconsidering, to be honest, this case, we'd be reconsidering whether this was possible or safe for the patient to undergo.
So yes, this is very. I think you include everything of interventional cardiology already, because from peripheral to the heart. Congratulations for the whole team. And then I had a question for panel, for faculty and audience, that in this situation, do we need to, if you don't have every device like this, so shall we open the RCA first? In some situation, I also open the CDO first. If we deal with the left coronary system, so I think the chance of the patient collapse on the table is really high. So what do you think? The CDO on the RCA first. Alan Chan?
Yeah, this is a really challenging scenario, but from the angiogram, from the history, the RCA was a chronic total occlusion, calcified. I think the investment in opening up the occluded RCA very calcified could be higher. But the chance of complication was also higher, and likely you may not able to go just for antegrade approach. You may still need to go for a fractomy, and the gain from opening up the RCA in this scenario may be, I think, if you want to invest, I think probably left side is better to invest. I have agreement that that case definitely need to support, but the degree, I think there's a lot of debate just before. Usually our approach is whether how aggressive are you going to treat the coronary, in particular if you contemplating a fractomy, multi-vessel fractomy in reality, probably IBP may not be inadequate. And I think from you just saw, I don't know exact details, but from your pressure tracing, to me, it's kind of uncoupling. Of course, you may have other issue of bleeding, but in case of bleeding, usually the blood pressure also drop. But the still image you're showing is just the loss of pulse pressure of the patient. The mean pulse pressure is still maintained around 80, 90 something, according to the snapshot. Of course, usually the patient is fine. Of course, it was totally supported by the impeller, right? But unless you have other issues, you have other subsequent hypotension. If you mentioned there is also breathing issue for the Crohn, then the patient start agitated, and agitation and desaturation probably is a sign patient is decompensating instead of really purely supporting by the impeller. So I think I would do the same. Try hard to use microaxial foam technology to support the patient and do multivessel PCI. I think also tackle the left side. I think the gain will be much higher. And once you open up the left side properly, hopefully the LV ejection fraction may improve. I don't know how he's doing, but usually they're the biggest territory surprising the myocardium, and then you're getting best out of it. Yeah.
Yeah, shortly. If I do not have impeller, maybe I will try to open the RCA first for a backup to the red main intervention.
Actually, why I mentioned it, because I also had a case like this with a very complex anatomy on the left side, not occlusion, but the very complex, and I think we can finish within around 15 minutes or something like this. So I tried to open the RCA first, and luckily that I opened it first. But after that, after both dilatation with the stented segment, so it's rupture the RCA, really the deep calcium. So the patient collapsed. But in this situation, the dependent flow from the RCA back to the left. So luckily we use the cover stand and seal the bleeding. So that also the option for the cath lab without any. You have almost everything at the cath lab, so you can perform this very complex case. So congratulations again.
Shall we go on?
Yes. So I think we still have a lot of questions for the first case, and I think we have to move to the next one. That